Hello doctors, we are going to answer some past papers. You can see that these are recalls. These are from 2012. So important point here would be that you need to cover full syllabus. You need to do MCQs from standard textbooks as we are guiding you in our course. These recalls, they are just highlighting the important topics, and the purpose is you should know what type of questions are asked in the exam and how you should be answering them. It is never advisable to just stick to these questions and keep answering them. This would be false reassurance. You need to cover your full syllabus, like I have told you guys in my previous webinars. Read very well. You should be knowing the basics as given in the MRCOG syllabus. This list was released by RCOG, Royal College of Obstetricians, in 2019. Just go over that one. It's very important. It is going to help you in acquiring all basic knowledge before you start your journey as a resident in the OB-GYN, and you can train to become a specialist. So why it is important? Because it is giving you the foundations of basic sciences which will be helpful in understanding the disease conditions, their pathophysiology, their suitable investigations, what is the rationale for carrying out these investigations, and how you are going to diagnose finally. And then you should know about the skeleton of this management, and you should be able to tell your patient that what they should expect. First question is, pudendal nerve, what is the relation to the pudendal artery? You should remember this is very important question because pudendal artery is the main artery of the perineal region. So you should know about the pudendal nerve and the pudendal artery. The pudendal nerve, it passes between the piriformis muscle and coccygeus muscle, or you can say ischio-coccygeus muscle, they are the same muscles, and it leaves the pelvis through the lower part of the greater sciatic foramen. It crosses over the lateral part of the sacrospinous ligament and re-enters the pelvis through the lesser sciatic foramen. After re-entering the pelvis, it accompanies the internal pudendal artery and internal pudendal vein upwards and forwards along the lateral wall of the ischiorectal fossa. It is being contained in a sheath of the obturator fascia, which is termed the pudendal canal, along with the internal pudendal blood vessels. Very important to know all of this information, through which foramen it is entering the pelvis and through which it is leaving the pelvis. Don't confuse them. And this question I have seen invariably in all exams. Question number 2. Reduce partial pressure of the carbon dioxide. So, decrease of the arterial pressure of the carbon dioxide, it leads to hyperventilation. It reduces the blood flow to the brain. Reduced arterial pressure of the carbon dioxide, partial pressure of CO2, it occurs in anxiety, panic attacks, and certain medications. It can occur in infections, central nervous system lesions, pregnancy, and also pain. It can be due to stimulants or excess thyroid stimulation. The question was that a pregnant woman is there and she is hyperventilating. So what is the physiological reason for it? So the reason is reduced arterial PCO2, and it occurs in normal pregnancy, and which is true, and it occurs at high altitude over 2,500 meters, that is also true, and it doesn't increase the cerebral blood flow, and it leads to more alkaline urine. So reduces blood pH. This is false because hyperventilation causes loss of CO2 in the body, causing the pH of the blood to increase and become more alkaline. And when the blood is more alkaline, hemoglobin binds more tightly with oxygen. That is the point. So this is the reason. This is a compensatory mechanism of the body. So this is washing out CO2, so which is eventually going to increase the pH of the blood. It will go towards the 7.3 or 7.4. Okay. Another question number 3 was that from where we are getting the immunoglobulins. So the from the beta lymphocytes we are getting the immunoglobulins. So it had different options like lymphocytes. You should know that they consist of three types of cells. There can be, as you know, the cells they are taking origin at the same point, but they will come from the bone marrow, but their maturation will take place into different parts of the body. So that's why where they are maturing up, we are giving them the same name. So the T lymphocytes, T cells, they will mature into the thymus. That's why the name T cells. B cells, they will be maturing into bone marrow, and that's why we call them B cells. So the T cells, they make up like 80% of the all lymphocytes, and the B cells, they make up 15% of the cells. And the third type of cells we are going to have, these are the natural killer cells, which are almost like 10%. So they are more specific for major histocompatibility class 1, and they have CD16 receptors. Which cells? Beta cells. B cells, they are more specific for major histocompatibility complex 1, and they have CD16 receptor. And decidual natural killer cells, they are present in the pregnancy, and they stain positive for CD56, but they are negative for CD16. So important points, so they will give you either CD16, they will give you these numbers, and you will have to identify them. So that which one are more specific for the CD16 and which one are more specific for CD56. They can be detected by these CDs. So remember some important points about B lymphocytes. B cells, they mature in the bursa, which is equivalent to the bone marrow. They differentiate into the plasma cells. Plasma cells are going to produce antibodies. We have got 5 types of antibodies: IgG, IgM, IgA, IgD, and IgE. IgG is the smallest one, and this is going to cross the placenta. IgM is going to be the largest one. So this is the IgG is the smallest one, and it is able to cross the placenta, so it can give like passive. That's why the babies, they can get some passive immunity from the mother. IgM is the largest immunoglobulin. It has got like 5. It has like 5 sites for binding the antigen. So it is large. So it is pentamer, found in the acute infections. Then IgA found into the secretions, IgD non-specific, and IgE, it is released whenever there are allergic reactions. So they are present. They present antigen. Who presents antigen to the T cells? B cells, or they can be like antigen presenting cells, APCs, which will groom the virus or other substances and present them to the T cells. And they also produce IgE, which is true, and they produce antibody, that is true. And they do not, B cells, they do not produce complement. B cells are not produced by the complements. Very important point, that is not function of the B cells. Question number 4. Which structure develops onto kidney and the renal ducts? They are asking you which one will finally make up the kidneys and the urinary system. As you know that kidney development, it will go through 3 different stages, and they will be like they will go away with passage of time because they cannot take up mature function. And the metanephros, they are going to develop the mature system, that is kidney and the renal duct. Okay. So remember this metanephris, that is going to give rise to the adult kidney. Question number 5. HIV viral loads test, they are reported as the number of HIV copies in a milliliter of blood. How many copies per ml? And like you can say that less than 50 copies per ml. And that is how the viral load is represented. Don't confuse it with the CD4 cells. CD4 cells are going to tell you that how good or bad your immune system is. That is the reason. Okay. So viral load is typically reported as copies of HIV in a milliliter of blood, and changes in viral load, they are usually reported as long changes, as a log change, that is the power of 10. For example, a 3 log increase in viral load, like 3 log 10, this is an increase of 10 raised to power 3 or 1000 times the previously reported level, while a drop from the 5 100,000 to 500 copies, it will be a 3 log drop. Also you can write it 3 log 10. That is the way of representing it. So here the question was that how the viral load is reported, and you will have to mention as copies per ml. That is the way of writing. Okay? How many copies of the virus per milliliter of the blood, copies per ml. Okay, if the copies are less than 50 copies per ml, then it means that patient has been receiving the treatment and the patient is good. That is the reason. Okay, and even at that level, you can allow your patient to go for normal delivery. Actually, we produced a good video last week. It was about post-exposure and the pre-exposure prophylaxis of the HIV. And you know the guidelines, they were changed in April 2021. So it is advisable to go and listen to that video. You are going to get many questions from there. Question number 6 is 60 years old female smoker patient in the ward for pre-operative preparation for abdominal hysterectomy and due to endometrial carcinoma. So which investigation of the following you don't require? So this patient is a cancer patient. Her environment would have changed a lot. So in this patient, you need to carry out all investigations, but we don't have the clue. Remember that these are the recalls. Okay, so we do have no idea that what was the actual question. So here you can do without this one, like the coagulation profile. Why? Because the cancer patients, this is based on the, in real life, we are carrying out all the tests, but for the exam purpose, when we carried this one out, then we knew that they were testing your concept that this patient is already having a hypercoagulable state, so you don't expect that it is going to prolong and it will not cause bleeding like that. So you can do without it. So not a very good question, but question is a question in the recall, so we have to answer that. Question number 7 says 50 years old female had hysterectomy 2 hours ago and the nurse noticed that the urine output was 35 ml per hour in the past 2 hours. So what is the normal rate of urine output per hour? So the normal rate they are asking you, she has passed like 35. Let me tell you that she is fine because 35 is still acceptable. Because it should not, the urine output, according to some guidelines, it should not be less than 30 ml per hour. Why? Because the minimum rate we expect is 0.5 milliliters per kg per hour. So this is the minimum rate at which the urine should be formed. If it drops below this point, then it means that patient is going to develop other complications, like there can be acute cortical necrosis, acute tubular necrosis. Why? Because of hypovolemia. So you have to pay attention to the wording of the question, that what exactly they are asking you. So okay, then in the question they gave a woman who was young and she has developed some heart attack. So then the question was that which of the following drugs she has taken, and that's why she has developed myocardial infarction. So the answer was cocaine. Why cocaine? Because cocaine is a vasoactive substance and it can cause vasoconstriction, and if there is severe vasoconstriction, then it can compromise the blood supply of the heart also, and the patient is going to have ischemia. That is one thing. Similarly, cocaine, it can also cause sudden IUFT. Why? Because because this is a vasoactive substance, so it can cause severe vasoconstriction in the cocaine users, and the baby can be IUGR, and it can also cause abruption, and it can also cause IUFT. So that is the importance, and you need to ask your patients at all occasions that your information is confidential. Are you abusing any substance or what, like that? Another question which is asked in each exam, that is abdominal aorta divides into two common iliac arteries at the level of which vertebra? Your answer is L4. These levels are very specific. I have made a separate video on the levels. are important landmarks where other blood vessels are arising, or the nerves, they are lying at the root values of the nerves, and where the blood vessels are originating from the larger blood vessels. Remember them very well. Okay. So L4, that is an important landmark where aorta is dividing into two. Okay, question number 10, list of potential benefits of combined oral contraceptive pills. Combined oral contraceptive pills, they have many uses. In addition to their contraceptive benefits, they have non-contraceptive benefits also. Like they can cause 50% reduction in risk of ovarian cancer and endometrial cancer. Improvement in the acne and in the appearance of the skin in the young girls, and reduction in heavy menstrual bleeding. Why? Because it will control, decrease this, now the whole system has been regulated, so it will prevent excessive growth of the endometrium, which is under the effect of estrogen. Regulation of menstrual cycles, alleviation of dysmenorrhea, and treatment of hirsutism and polycystic ovary syndrome. And this is also treatment of premenstrual syndrome, and it will cause, before it was said that it will cause a reduction in the risk of colorectal cancer, but now the studies are divided. They have no effect on the results of dementia or other problems. So the actual question was, colorectal cancer is protected by COCPs. So if you will go to the Allison's book, it says, the literature says different thing, but this book says that it is going to cause a reduction in the risk of colorectal cancer by 15 to 20%. So we will stick to this answer, that yeah, the COCPs, they decrease the risk of colorectal cancer by 15 to 20%. So question number 11, there was some patient who had suprapubic pain and leukocytosis. So the suprapubic pain and leukocytosis, then you have to think about other problems. So there can be two options can be there. Like this patient is having suprapubic pain and leukocytosis. So maybe she is having PID, or maybe she is having cystitis. In case of cystitis, your patient will have vague suprapubic pain, but she will not have any fever. This is important point. If your patient has urinary tract infection and she has fever, you have to think that she is having full-fledged infection, and this is not only cystitis. But if your patient has cystitis, then she will have only suprapubic pain and there can be leukocytosis. So you will have to read the question very well before deciding on the answer. So read what other history factors are given there. Next question is the phases of eukaryotic cell division in which cell can undergo into quiescent stage. So the cell is into the quiescent stage, so we will say that this is G0. Very important to know about the cell cycle, because in each exam they are asking you questions about cell cycle. The cell cycle, this is the process a cell undertakes to replicate all of its genetic material and divide into two identical cells. So here we will look at different stages of the cell cycle, because they are always asking you in the exam. So the cell cycle, this is a 4-stage process consisting of a gap stage or gap 1, G1, synthesis S, gap 2, G2, and the mitosis, and which a cell undergoes as it grows and divides. After completing the cycle, the cells, they either start the process again from G1 or they can exit the cycle through the G0. Right? So from G0, then the cells, they can undergo terminal differentiation. The stages in the cell cycle between one mitosis and the next, which include G1, S, and G2, they are known collectively as the interphase. So G1 phase, here the cell increases in size and cellular contents, they are duplicated. In the S phase, DNA replicates, and each of the 46 chromosomes, like 23 pairs, it is replicated by the cell. In G2 phase, cell grows more organelles and proteins they develop in preparation for the cell division, and in the M phase, the mitosis, which is followed by cytokinesis, that is cell separation, and it will result in formation of two identical daughter cells. G0, which some cells they are consistently dividing, some cell types they are quiescent, and these cells they exit G1 and they will enter a resting stage called G0. In G0, a cell is performing its function without actively preparing to divide. G0, this is the permanent state of some cells, while in the others it may restart division if they get the right signals. So signaling mechanism is also very important. So in the cell cycle, this is the G1 where the growth is taking place. Here in the S phase, DNA synthesis. In the G2, gap 2, growth and preparation for mitosis. And M is going to show mitosis. They can give you different areas and they can ask you that they will, without writing anything, that identify the stage of the cycle. Because now with the computer-based test, they can ask you different questions like that. Okay. Then question number 13, the stages at which DNA is checked. DNA is actually doubled, so the stage is G2. So important is that these points are very important when regarding the checkpoints. There are 3 checkpoints within the cell cycle, and these indicate points at which cell cycle it can be stopped in order to ensure the fidelity of the process. Fidelity that the process is going correctly, so it is a type of quality control. G1, as I said, that this is also a checkpoint, and the checkpoint that lies between the G1 phase and the synthesis phase, once overcome, it marks the end of the extracellular signaling being able to influence the progression of the cell cycle. The checkpoint is regulated by a CDK inhibitor that can only be overcome by an increase in the level of the cytokines, which is stimulated by growth factors. And the checkpoint is often referred to as the restriction point. G2 checkpoint, the checkpoint it lies between G2 phase and M phase, and the DNA is checked along with other features of the cells in order to ensure that it is eligible to undergo mitosis. I mean there are no defects and they can proceed for division without any fear of having abnormal DNA. Then third point is metaphase checkpoint. During metaphase in mitosis spindle, microtubules they attach to the kinetochores located on the centromere of the chromosomes, and they allowing the separation of homologous chromosome chromatids in anaphase. The checkpoint is aimed at ensuring the correct attachment of the microtubules, and this is assessed by the tension in the microtubules and the presence of the molecules that inhibit anaphase until attachment has occurred. Failure at this checkpoint it can lead to aneuploidy. Aneuploidy means abnormal number of the chromosomes, can be more chromosomes, can be less chromosomes. And the examples of the aneuploidy, these include the Down syndrome and the Turner syndrome. Some cancers, they are also associated with an increase in the number of the chromosomes as they lead to the overexpression of certain genes. An example is acute myeloid leukemia, which comes from an addition of copy of chromosome 8. So these are the cell cycles and you should be very clear about them, because anyhow they are going to ask you a question about the cell cycle. Question number 14. Which ascending artery can be damaged during an open appendectomy? So the point is, which artery can be damaged at this point? Like what? So what is the point? The point is that you are doing appendectomy, so they are asking you that which blood vessel can be damaged at this point. So if you look at the structure, you will find that superficial circumflex artery, it lies here, so it can be damaged during appendectomy. Actually, you should read this question very well, that this procedure was done as a laparoscopic procedure or as an open procedure. If we will talk about the blood vessels around the appendix, then you should know that around the appendix you are going to see several blood vessels. Like superior mesenteric is the blood supply, main artery here, then iliacoelic artery, then inferior division of the iliacoelic artery, and then the anterior cecal artery and the posterior cecal artery, and here is branch of the appendicular artery which is going to supply, but it is getting some peaks from other blood vessels also. This is the superior division of the iliacoelic artery. So if they're asking you about the appendix in particular, then you should know that which procedure was done. Basically here they are asking you that if they are introducing the laparoscope, which blood vessel can be injured. So when they are inserting the primary port, aorta can be damaged, and when they are inserting the secondary ports, then other blood vessels they can be damaged. So if they ask you that, they tell you that which port was entered or at the time of primary port insertion or secondary port insertion, then you will have to identify the question and then answer that. Otherwise, generally speaking, these are the blood vessels, so maybe superior mesenteric, it can be damaged at this time. When we are introducing the secondary port, then inferior epigastric artery that can be damaged, which is a branch of the external iliac artery. This question they are often asking you in the exam. That is one thing. Okay. Question number 15. When you hold the bony pelvis in anatomical position, which two landmarks are at the same level horizontally? So you should know that pelvis is tilted forwards, and then symphysis pubis and the ischial spines, they are going to lie at the same level in the horizontal plane when we are adopting the normal anatomical position. You should remember that the bony pelvis is formed by the hip bones in front and at the sides, and by the sacrum and coccyx behind posteriorly. So when a subject is in the anatomical position, the anterior superior iliac spines and the pubic tubercle, they are in the same coronal plane, and the pelvic surface of the body of the pubis on which the bladder rests, it will face more upward and than the back bones. The pelvic surface of the sacrum, it faces more downwards than upwards, than forward. So that is the natural position in which the symphysis pubis and the ischial spine, they will lie in the same plane. Next question is submentobrachmatic diameter. Very important for you to know about the diameters of the fetal head, and they can give you different names for it, and which one is the normal, which one is the largest diameter. These things should be on your fingertip, because these are easy marks. You just have to recall the facts and you can answer the question. So submentobrachmatic diameter is 9.5 centimeter. Biparietal diameter, important for you to remember, biparietal, suboccipitobrachmatic and the submentobrachmatic diameter. These all are 9.5 centimeter. Bitemporal diameter, that is 8.5 centimeter. Occipitofrontal diameter, like in the vertex presentation, it can be 11.5 centimeter. This is the fetal head. Important for you to recognize all diameters. Like this is occipitofrontal diameter, so it is starting from the root of the nose and this is going to the occiput. So this is 11.5 centimeter, and this is vertex presentation of deflexed head. Normally the head should be flexed, but this is deflexed, going like occipitoposterior, so this is going to be 11.5 centimeter. Then look at this one, submentobrachmatic diameter. This is face presentation. So if they tell you that you are able to feel the tip of the nose of the baby, then it means that you are feeling the face of the baby. So this is face presentation. So it is going to be, this is the submento, and this is brachma. Submentobrachmatic diameter, which is 9.5 centimeter. The normal diameter, normal means that most of the children, they will come with that diameter when the head is flexed. So that is the vertex presentation. The size will be 9.5 centimeter. It will be extending from the occiput to the bregma. That is the vertex presentation. If they tell you that the baby is like you are able to feel the brow of the baby, then you will say that this is brow presentation. So it is going to extend from submento from mentum, that is the chin, mento to the vertex. So vertomental diameter, that is 13.5, and it is broad presentation. So this is very large. Okay, so we have to deliver the baby by cesarean section because the head is too much extended. Then occipitotemporal diameter. Occipitotemporal diameter means that like it is extending from the occiput to the temporal bone, and it is going to be 12.5 centimeter. So it is also large, so we will have to assess, and most likely the baby will go for cesarean section. So you have basically got 5 diameters. Just remember from where they are extending, where they are coming, and where they are going, because they are in each exam they are going to ask you this question. Very, very important. Remember the landmarks, remember the sizes, and these are like easy marks, so don't lose them. Another diameter, suboccipitofrontal. So pay attention to occipitofrontal and suboccipitofrontal. Suboccipitofrontal, it is good, occipit. The sub means below. So this is occiput, so suboccipitofrontal, root of the nose, okay? That is going to be 10.5 centimeter. So these are important diameters to remember. You should have very clear idea about the fetal skull. This is the bregma or anterior fontanelle where the 4 bones are meeting. So this is diamond shape, and the posterior one, here the 3 bones are meeting. It is smaller one, and this is triangular in structure. If you will look at the sutures, this is the sagittal suture, this part. Sagittal suture, which is lying between the 2 fontanelles, and here we have the frontal suture, and which is lying like in between the 2 frontal bones. On the sides, here are the coronal sutures at the junction of the parietal and the frontal bone. So this is the coronal suture, okay? And this is the widest part, that is the parietal eminence. So then you should know the other diameters, which one is the suboccipitopragmatic, submentobregmatic, and this is our occipitofrontal diameter, and this is the mentovertical diameter, and then this is like occipitofrontal, this diameter you are looking at, this one, this is the face presentation like that. So that is one thing. And where is the what of the baby? All of these things should be very clear in your mind like that. Then the diameters, the smallest one is the bitemporal, 8.5, and then this is the greatest distance between 2 halves of the coronal suture. Your definitions should be crisp. Try to learn them. Biparietal diameter between 2 parietal bones, between 2 parietal eminences, so that is 9.5 centimeter. Then suboccipitopragmatic and bitemporal diameter, that is the circumference, which is 28 centimeter. Occipitofrontal and the biparietal, that is going to be 33 centimeter. So these are engaged diameters of deflexed vertex presentation and found in occipito posterior position. So you can see that difference of 5 centimeter between the vertex presentation and because it is in the vertex presentation, and this one is in the deflexed head. So lot of difference. Then mentovertical and the biparietal, that is going to be 35.5 centimeter, and this is the largest circumference which you can see if there is broad presentation. That's why in broad presentation the baby cannot be delivered in a normal way, so we have to offer cesarean section. Please remember this stuff very well. Question number 17 is, what is the frequency of transvaginal ultrasound scan? The answer is 7.5 MHz. Important to remember that what are the differences between the abdominal and the vaginal ultrasound, what are their frequencies. These are very easy marks where you don't have to dig in a lot, so you should try to answer them well. Okay. Question number 18. What makes a dimple or sulcus in the gluteal region? The answer is posterior superior iliac spine. Posterior superior iliac spine. Also remember that dimple is just above the buttocks, and it is going to define S2, that is the sacroiliac joint, termination of the dural sheath, and posterior superior iliac spine. So this is an important landmark, you should know about it. Question number 19 is, The whole scenario was given, but the next step of management for a woman who has hemoglobin of 6.2%. So what should be done? So you need to arrange 2 units of the packed RBCs. Maybe this woman was a sickler, or maybe she was a thalassaemic. So it was like a similar question like the question number 10 20 given in the endocytes. You should basically know about the pathophysiology in the hemoglobinopathies and how we can fix them. So just be very clear about the changes about the pathology in cases of thalassemia and in the sickle cell disease. Question number 12, and then you should know the clear indications for blood transfusion and when you don't have to do blood transfusion, and you can increase the iron level just by giving oral iron therapy, or you can give parenteral iron therapy. All of this detail has been discussed in anemias during pregnancy. Please refer to that video. Question number 20 is about Bayer's theorem. So we don't know that what exactly was there, but the theorem says that the prior odds of having a condition multiplied by the likelihood ratio, this is derived from the test and utilized, and then posterior odds. So this question is not clear, so if somebody finds a better version, then we can talk about this one. Next question, but you should be very clear about all of these ideas which are given, but we will talk about this. I will give you some better questions on it. Question number 21, what is DEXA scan? So the DEXA scan was carried out. So at one point you will say that the woman has some problem, and when you will say that woman doesn't have a problem. As you know that this DEXA scan is dual X-ray absorptiometry test. It is going to tell you that how compact are the bones and what is the likelihood of having osteoporosis. So we are basically mentioning two scores, T-score and the Z-score. Both are equally good. They have been validated, but the T-score is given more importance than the Z-score. So our T-score is within the normal range if it is -1 or above. This is -1. -2, that will be lower than this one, okay? But if it is -1, 0, +1, +2, +2.5, so that is better. So what abnormal result means? Abnormal result means like when the bone mineral density is less than -2.5, it will show you that the bone mineral density testing, it doesn't diagnose fractures, although it will tell you that the bone is thin and it is a risk factor for the fracture. So what is the risk of having fractures in the future? So if a T-score is like between -1 and -2.5, it means that the patient has early bone loss, and we call it osteopenia, and this is a reversible condition. If it is below -2.5, then we diagnose it as osteoporosis. So, and the treatment is going to be different. We will talk about the treatment of osteoporosis when we will cover pharmacology. Regarding the Z-score, mostly they are not giving you, but if in case they give you Z-score, then you should remember for the Z-score we are using similar values, and this Z-score is basically favored by the PACS people, by the International Society of the Orthopedicians, and if the Z-score is less than 2, then it means that your patient is going to have osteoporosis. Z-score is more than 2, it means your patient has no risk. So this is required for the diagnosis of osteoporosis. That is the point. Question number 22. What is the type of the cells lining the labia majora? So you should know that that is keratinized stratified squamous epithelium. And also remember that the labia majora, labia minora, and the clitoris, they are covered by keratinized stratified squamous epithelium because they are exposed to the external environment. That is the reason. So they have, whenever the skin is coming into the direct contact with the exterior surface, with the external environment, it is covered by the keratinized stratified squamous epithelium. Okay, so the basically question number 13 was about causes of ovarian failure. When it is occurring prematurely, because we call it premature ovarian insufficiency. the chance of having premature ovarian insufficiency is like almost 1%, and most common cause will be idiopathic, where we have not found anything. Then it can occur in association with some genetic disorders like Turner syndrome 45X0, and it can occur in cases of Turner mosaic like 45X, 46XX. It can also occur in gonadal dysgenesis, and you should remember gonadal dysgenesis, that is the most common genetic abnormality that anyone can inherit. That is the point, okay? So like in the gonadal dysgenesis, the chromosomal composition can be this one, but as the name dysgenesis means, the gonads are not formed. So this is the most important and the most common cause of primary amenorrhea also. You can get different mosaics, okay? Trisomies 18 and 13, that is Edwards syndrome and Patau syndrome. Theoretically these are correct because usually the children, they will die within first year of life and you are not going to see them. Then these can be due to X chromosome deletion or translocation. So all of these are genetic causes of having premature ovarian insufficiency. Never say premature ovarian failure because that is a misnomer, okay? So premature ovarian insufficiency, these are the genetic causes. Then they can be autoimmune in origin. Regarding the autoimmune, remember the important diagnosis, like maybe they can be due to autoantibodies like the antinuclear antibodies, like in cases like lupus, anticoagulant. Then they can be due to polyglandular autoimmune syndromes. Like antibodies, they can be against thyroid, parathyroid, and adrenal ions of cells of the pancreas. Like in the men's, like multiple endocrine neoplasia, this condition can occur. Third important cause are infections. In the infections, you should know that like tuberculosis, like mumps, like there is destruction because these two infections, they can destroy the germ cells, so your patient can present with premature ovarian insufficiency. That's why very important to take history of these disorders. Iatrogenic is anything which is resulting after R or the medical intervention, like radiation therapy, chemotherapy, and the most notorious substance, the most gonadotoxic substance is going to be cyclophosphamide, okay? Whenever you are starting this cyclophosphamide therapy for the children of the like adolescents or the women who are or the men who are in the reproductive age group, you have to refer them to the fertility specialist who can take their germ cells like the semen and the ova, and they can be frozen, or they can even take out the tissue, stripes of tissue, which can be reimplanted after the surgery. And why? Because because cyclophosphamide is very gonadotoxic, and it can cause sterility, so the children, they won't be able to reproduce later. So advisable, whenever you have a teenager or a woman of reproductive age or the man of reproductive age and they are going to take up this therapy, you need to refer them to the fertility specialist. And then in cases of as a result of surgery, then they can be due to metabolic disorders like galactosemia, 17-alpha hydroxy or the congenital adrenal hyperplasia syndrome, which is the most common endocrine cause of having premature ovarian insufficiency. Then the environmental factors like smoking. Then FSH receptors, they can be absent, or post-receptor defect can be there, like in cases of Savage syndrome. So patient will have history of amenorrhea in the less than 35 years of age, and the serum gonadotropin levels like FSH will be more than 40. You should know that the serum FSH level of more than 35 is required on at least 2 different occasions when the blood sample has been taken 4 to 6 weeks apart. This is required for the diagnosis of premature ovarian insufficiency or menopause. And when the serum E2 level, estradiol level is low, and the karyotype abnormality can also be seen. So then the gonadotropin, and then organ specific like the humoral antibody can be there. So many defects can be there, but these are the main defects. So the ovarian biopsy, like the afollicular, follicular, and the autoimmune variety, that is not essential for the diagnosis, and we don't have to take any cells, we have to just take the hormonal levels. Sometimes there can be other rare disorders like the resistant ovary syndromes. The follicles will be present and FSH receptor is either absent or defective. So you are going to find a very high level of FSH because the FSH is trying to stimulate the ovaries to recruit the eggs, but either the receptor is deficient, absent, or it is defective, so no result will be gained. And patient can present with amenorrhea, which can be primary or secondary, and features of the hypoestrogenic state like the menopausal syndromes like the hot flushes, vaginal dryness, dyspareunia, and psychological symptoms that they will be presented. And the possibility of autoimmune disorder, it should be considered below the age of 35. And for this, anti-thyroid antibodies, pneumotide factor, anti-nuclear antibodies, they should be measured. In younger patients like below the age of 30, karyotype is to be done to rule out chromosomal abnormalities. In each exam, they are going to ask you at least 2 questions on premature ovarian insufficiency, so you should try to remember them. Question number 24. Insulin get active by removing which part? So you should know that insulin is produced as proinsulin, which will change into the proinsulin, and then the proinsulin, when the C peptide is cleaved, then it will give rise to the active hormone, which is insulin. So if the patient is taking insulin exogenously to get some medical benefit, in that case you are not going to get the C peptides because the patient is already taking a preformed hormone. That is the reason. Okay. Question number 25. Anterior fontanelle closes at which age? At what age? So the answer is at 18 months. Okay. So fetal skull is very important for you. You should know that the number of the fetal skull fontanelles, basically they are 6 in number. Don't think that we have only 2, like the anterior and the posterior. Anterior and posterior, they are like more important, we are talking about them, but you should know that there are 6. 1 anterior, 1 posterior, 2 are going to be sphenoidal, and 2 are mastoidal. Okay, these are the 6 foramen in the fetal skull. Anterior fontanelle at phlegma, and this is bordered by frontal and the parietal bones, like I have shown you before, diamond shaped, and it is going to close at 18 months of life. That is the one point. Okay, and the posterior fontanelle, this is bordered by the parietal and the occipital bones, and it closes at 2 months of age. So sometimes they can ask you that which one is going to close, which foramen is going to, fontanelle is going to close early. Then your answer is that the posterior one is going to close early and followed by the anterior. Okay, thank you. Remaining questions we will do in the second sitting. Thank you very much.